Our first speaker in the retinoblastoma awareness around the world session is Minh Chau, who is a pediatric ophthalmologist in Hanoi, Vietnam. So welcome, Minh.
Thank you. Vietnam, good evening, but in USA, and Sandra is good morning, everybody. I'm very happy to be here. It's the first time I'm here, and I think I could learn or discuss something in retinoblastoma, and it's could improve in Vietnam treatment retinoblastoma. The topic is retinoblastoma in Vietnam on the way, because I think Vietnam is one of the developing country. We before 10 years ago we called the poor country, but now we in the way on the developing, and I hope retinoblastoma in Vietnam is on the way too. In Vietnam now, the population is so crowded. We have nearly 100 million people, and every year we have 1 million and 500 newborn babies. So the retinoblastoma is not little, it's not few, it's about 80 to 100 new cases a year. And because of Vietnam is a country so long, and we divide the most center to treat retinoblastoma is a Vietnam National Eye Hospital, where I work, and Ho Chi Minh Eye Hospital in the south of Vietnam. And now we have a pandemic, the COVID in the south, and it's not good for the children, especially for the albeit children. And we collect the data from 2007 to 2019. So you see, is before 2013 is about 20 to 30% new patient per year, but now it's about 60% new LB patient per year. It's only in my hospital in the north of Vietnam. In the north of Vietnam, that's why we had the year of 2013. We explain after. Before 2000, so you see the most LB children in Vietnam is enucleation, and we only do keep this the eye when the tumor is under 3 millimeters with the laser and cryo. If the tumor bigger, we put it to keep the eye, and less contact with the ophthalmologist and oncologist. Some patients go to ophthalmologist, and we only do the enucleation. And some patients with the extraorbital or something we call the cancer, they go to the cancer hospital, and there they only do the chemotherapy, and we don't know the patient is a survivor or not. And the high refuse and abandonment treatment, and we and 10 years ago, is a extraorbital LB is high in Vietnam. And we had a lockdown from 2000 and 2013 when the economic developed. So we have less extraorbital retinoblastoma. So, but we had no screening LB family. So we have a unilateral or bilateral father or mother has been enucleation 10 years or 20 years ago, and they come with us. They came with us with bilateral sibling, and most of or half of them must be enucleation. And when you see the diagram, we have a family is 3 children died with the retinoblastoma, and the last children we could see one eye. And no compensation treatment group is when the tumor is bigger. And the year 2013 is we call is amazing years for us. We had Dr. J. Mickey from SciFo to come with us, and in the last the second day of meeting, you listen from the side for all. They say Dr. Jim Mickey said that, oh, it's incredible treatment in the LB patient, because we had nothing in the eye, in the hand to treat, and we had a office of Flying Eye Hospital to have a specialist to come to teach us about pediatric ophthalmologist and retinoblastoma treatment. And we had a contact with the Institute of Curie from France to give the, some specialists to come with in Vietnam to talk about the retinoblastoma treatment. And after that, I had lucky to come to India in LV Prasad. And you see here is Dr. Swathi Kaliki. At that time, I only learned from the pediatric ophthalmologist. But when I see the amazing work to treat retinoblastoma children in India, I think why in India they could do like that, but why in Vietnam we only enucleation and we haven't got the follow-up or supervisor from of the retinoblastoma patient. So at that time I asked Dr. Swathi to follow her to learn, and luckily she taught me so much about the retinoblastoma. And after come back, I do the research about a PhD about the ocular in retinoblastoma in Vietnam. And now the treatment retinoblastoma in Vietnam, we apply the classification in ICRB, but no AGCC. And with the focal treatment, we had laser, we had cryo, but the laser is not good because now we use for the ROP, the diode laser for this, and we hope to push by the new one. And in chemotherapy, we have IVC, intravitreal chemotherapy, and luckily from 2017 we begin to the first IAC, and now we have the 20 or 30 cases just now. That's is an amazing work of us. And we had radiotherapy, but we haven't got the blood for the treatment of retinoblastoma. And in the surgery, we could do enucleation or exenteration, but the ocular risk in Vietnam is not good, and we on the way to improve this. And here is some maybe you don't know what we do for the retinoblastoma in Vietnam. And after learning from somewhere, everywhere in the foreigner, and now we have some achiever in retinoblastoma, and but the truth that the patient come very late is all the way in the group E or D, one eye or even two eyes. So over 19% we must do the enucleation. But now we are on the way to keep more and more. We could keep the eye and the vision. And here we have a small research about the two conservation treatment in retinoblastoma. And the reason that the group A we could keep 100% and group B 19%, and even in group D with IAC we could keep some eye. The thing that before we only enucleation the eye of group D and E. And for the screening for the before we don't know the LB patient could survive or not, because we have no contact. But in the truth that the mother and or the father has a LB history, come with us with bilateral LB children. So we try to do the screening LB, and now we could do the genetic consult, but it's very expensive. We only find to the fund from the government, but it's only do a few patients now. And now in Vietnam, we had some difficult cases because the patient is monocular with the vitreous hemorrhage or recurrent or the group D or E both eyes. So it's very difficult for us, and we hope that we could do more and more to keep that eye like that. And for the extraocular retinoblastoma, before we not only we couldn't keep the eye and couldn't keep the life of the children, but now only the case metastasis in the central nervous system, we have no more treatment. But if only the orbit or optic nerve, we could keep the life of the patient. Keep the life of the patient. So I think it's on way of us to in the LB treatment. So we had in Vietnam, we had a crowded many patients. So we had the advantage and disadvantage like some other country, developing country. And we hope that we are in the future, we could have more advantage about this. And why I put on the way, I had a chance to meet, to go to the Australia to meet Sandra. And I know that if I only the ophthalmologist, I only treat the patient. So it's a very few. But if we could connect like the medicine with the multi-discipline treatment with the foreigner to help us in the treatment, and the other side we build the community to with the to improve the side of the glow or the early side of the retinoblastoma. So that means we could keep more the vision and the eye of LB patient. So now we are this year we begin to build the Vietnamese community of retinoblastoma. We translate all the information in English in Vietnamese. And thank you, Sandra, to have me. And finally, I hope that with the meeting, with the chance to come here to talk, and I think nothing we can do, we can change the past, but everything we could change the future of the of Vietnamese retinoblastoma children. Thank you so much.
That was wonderful. Thank you very much. And our next presenter is going to be zooming in via video, and that is Swathi Kaliki from Hyderabad, India, who's the head of ophthalmology at the Eyesight Universal Institute for Eye Cancer. So we're going to now play her video.
A very good morning. I'm Dr. Swathi Kaliki from Prasad Eye Institute, India. And I'm very happy to be a part of this One Retinoblastoma World Virtual Conference, and hopefully it will be a physical meeting next year. Today, I'll be talking about retinoblastoma in India. As we all know, retinoblastoma is the most common intraocular malignancy in children, and it represents 11% of cancers in the first year of life. While globally, the retinoblastoma, it represents 2 to 4% of childhood malignancies. In India, it represents 5 to 7%. The global incidence of retinoblastoma is 8 to 11 cases per million children less than 5 years of age, while in India, it represents about 20 cases per million children less than 5 years of age. While the incidence rates of retinoblastoma are comparable in different countries, the mortality rates are starkly different. The highest mortality rate is seen in Africa, where 70% of the children die because of the disease, while in developed nations, the mortality rate is only 3 to 5%. While in India, it is slightly less when compared to when compared to some parts of Asia where the mortality rates are at close to 40%. India carries a huge burden of the disease where we see about 1,500 new cases every year. Talking specifically about this topic about retinoblastoma in India, it is very important to create a strong referral base so that the cases are referred to us early in the disease so that we can treat these cases on time. And to create a good referral system, we follow this pyramidal model, which is called as the LVPI pyramid of eye care, where we have for every 5,000 population, there is a vision guardian. For every 50,000 population, there is a vision center. For every 0.5 million population, there is a secondary center. For 5 million population, there is a tertiary center. And a center of excellence can serve about 50 million population. So I serve at a center of excellence that's at Hyderabad in India. This forms our strong referral base for retinoblastoma. We also conduct a lot of advocacy activities to increase awareness about the disease, about the weight presence, how we can go about treating it. We do a lot of activities about it in general public, the teachers, and the regular medical practitioners as well. We also conduct an annual run. This is a marathon that is dedicated towards increasing awareness about retinoblastoma, which is called as Whiteathon, which indicates the white reflex in a child's eye. And these are the pamphlets that we usually distribute to the primary healthcare centers, to schools, so that there is increased awareness about retinoblastoma. Now, with all these strategies, the number of cases that are being referred to LVPI has increased over the years, starting from less than 5 cases in 1987 to about currently we see about 200 to 250 new cases every year. In addition to treating cases with retinoblastoma, we also understand the importance of training many more professionals so that they can treat the retinoblastoma patients in their locality, be it nationally or internationally, where there are national and international fellowships. The retinoblastoma team at LVPI is comprised of an ocular oncologist, medical and radiation oncologist, interventional neuroradiologist, trained nurses, pathologist, genetic counselor and geneticist, ocularistry team, rehab team, and basic research team. These are the dedicated OPD areas where we see children with retinoblastoma, such as this child. And we have a dedicated operation theater space to perform the examination under anesthesia once a week. We document everything that we see. These are the RetCam images that have been performed in a child with retinoblastoma, and also we document them by drawings and make sure that no detail is missed. Medical oncologist also visits the hospital so that the children are examined before giving the chemotherapy. And once the children get fitness for chemotherapy, chemotherapy is given in-house. This is the chemotherapy ward, which is located within the premises itself. And by creating this chemotherapy ward within the premises, it has reduced the dropout rates, and loss to follow-up rates are very less in our setup. This also creates a patient and parent support group so that the follow-up rate is good. This is the dedicated OR space where we perform surgeries for retinoblastoma, such as enucleation or plaque radiotherapy. This is the slide from our pathology lab where there is a dedicated pathologist who looks at these slides. And then once the eye is removed, of course, we replace it with a customized ocular prosthesis. This is one such example where the child has received a beautiful looking customized ocular prosthesis. And sometimes children may have low vision despite our best treatment efforts. In such cases, they are referred to the rehabilitation services, again, which are located within the premises itself, where they're given training about how to go about using the residual vision to the best of capacity. Coming to a little bit of data, this is the analysis that we did in close to 1,500 patients. The mean age at presentation of retinoblastoma in India is slightly higher at 29 months when compared to that of the West. The tumor laterality, as we can see, it's unilateral in about 60% of the cases and bilateral in about 40% of the cases. And these figures are somewhat comparable to that what we see in developed nations. While the most common presenting symptoms in the developed countries are leukocoria and strabismus, in our setup, leukocoria was seen in 75% of the cases, forming the most common presenting symptom. The second most common presenting symptom is proptosis, which accounts for about 6% of the cases, while strabismus forms about 5%, and the other symptoms like red eye, decreased vision, Extraocular tumor extension is seen in about 9% of the cases, and very advanced, such as stage 3, seen in 6%, and stage 4, that is with metastasis at presentation, is seen in about 3% of the cases. The most common primary modality of treatment that is used in India is intravenous chemotherapy, accounting for 60% of the cases. And enucleation as primary treatment is also quite common, which is seen in about 35% of the cases. Intra-arterial chemotherapy is performed in less than 10% of the cases as primary treatment, and other focal treatments are performed as necessary. Plaque radiotherapy is mostly performed as secondary treatment. With all these treatment measures, the life salvage rate is very good at 92%, while the globe salvage rate is only 45%. But salvage of at least one eye is definitely achieved in more than 85% of the cases. And in these eyes which have been saved, the vision salvage rate is good at 75%. And I'll end with this slide. Now, this is a wall that is present at LV Prasad Eye Institute. And these are the fingerprints of children who have survived cancer. This is placed just before the parents can enter into the clinic, just to reassure them that retinoblastoma is curable and these children can survive this deadly cancer. Thank you very much for this opportunity.
Thank you so much, Swathi. It was wonderful to have her presentation. Up next, we have Viviane Lanzelotte, who is a pediatric ophthalmologist joining us from South America in Rio de Janeiro, Brazil. Welcome, Viviane.
Thank you so much. I'd like to thank you so much, the organizers, for the opportunity to participate in this so important conference, and especially to Sandra, who I was fortunate to meet recently. And I'd like to emphasize that this presentation was made in partnership with Dr. Clarissa Matosinho, and we feel very honored to be invited. This is I'd like to introduce ourselves to you. This is Dr. Clarissa Matosinho. She's an oncologist ophthalmologist, and she works at the INCA, is the National Cancer Institute from Ministry of Health. I am a pediatrics ophthalmologist. I work in the City Hall Department, Health Department of Rio de Janeiro, and I am the president of the work group of ophthalmologists of the Paediatric Society of the State of Rio de Janeiro. And I would like to introduce you the institutions where we work too. And this is the INCA. INCA is the National Institute of Cancer. It's where Dr. Matosinho works, is a tertiary center for adult and pediatric patients located in Rio de Janeiro. And its integrated actions for cancer control and prevention are developed and implemented as an auxiliary branch of the Brazilian Ministry of Health. It's the main pediatric oncology center in Rio de Janeiro state, and it receives the majority of the solid pediatric cancer, and particularly most patients with retinoblastoma, once it's the only cancer center offering eye-preserving treatments in Rio de Janeiro, such as intraarterial and intravitreal chemotherapy. And in Rio de Janeiro, we have no private centers taking care of retinoblastoma patients. The City Hall of Rio de Janeiro, where I work in the health department, is in addition to other actions in ocular area of public health. It promotes red reflex training among pediatricians in general, neonatologists, and doctors at family health clinics. We also have set the protocol, the red reflex protocol, assessment in maternity before discharge, which is law here in Rio, and we set the protocol of performing the red reflex during child care up to 4 years too. And the SOPERGE is the Pediatric Society of the State of Rio de Janeiro. It aims to bring information and scientific updates to pediatricians through its departments, and also information to the lay public. With reference to the work of the ophthalmology group, of which I'm president of the 2019 to 2021 triennium. It performs red reflex training among the pediatricians in general and also promotes awareness campaigns and disseminates scientific information for early diagnosis of ocular diseases, including the retinoblastoma. Now we are going to the topic of this presentation. These Inca data from the pandemic period are preliminary and they are still being collected and reviewed. They had 30 retinoblastoma enrollments from January 2020 to September 2021. They had, in this group, they had 3 deaths. One of the deaths due to sepsis, as the family was unable to attend the hospital due to the pandemic. The child was left at home with fever, and when she arrived at the hospital, she was very ill. From this group, 50% presented with signs of advanced disease, such as glaucoma, ophthalmia, and proptosis. And they had 3 cases with metastases in the central nervous system at diagnosis. Before the pandemic, the usual average enrollment per year was between 20 to 30. So the number of 30 cases in almost 2 years, it's a point of concern. Could it be a sign of a decrease in referrals to the pandemic? There was greater difficulty in accessing cases, in accessing the care during this period of pandemic that we are still experiencing. In Inca, I have brought this case, is one of that advanced case, pre and post intravenous chemotherapy. In this period too in Inca, simultaneous bilateral enucleation was performed in a refugee child from Venezuela present with advanced disease in both eyes. This child received venous chemotherapy and is still alive. This is very worrying because the last case of simultaneous enucleation of both eyes was a long time ago. It occurred in the early 90s, and nowadays we have 1 case more too. These are red flags, so important points in Brazil. And during this period that we are still living with the COVID pandemic, we have hampered accessibility and mobility here in Brazil. The impoverishment caused by the crisis both worsens the diagnosis and makes adherence to treatment difficult. Fundoscopy protocols are more rigid and make fundoscopic evaluations more difficult. All these issues contribute to diagnostic delay and an increase in advanced cases, such as those that caused the 3 deaths previously reported. Cancer diagnosis in Brazil in the COVID-19 era. This is a recent study by Dr. Marques et al., and it aimed to compare SUS-oriented cancer diagnosis in Brazil before and after and during the pandemic so far. The Brazilian United Care System, called SUS, is the world's largest universal health care system, funded by federal, state, and municipal resources and serves over 209 million inhabitants. This study aimed to compare this data, and due to COVID, several restrictive measures have been implemented by the governments of the various states of the federation, such as physical distancing and closure of non-essential commerce in order to reduce the rate of contamination. Cancer diagnosis referral centers were also impacted by these measures. So the work concluded that the pandemic period has dramatically reduced the diagnosis of new cases of cancer in general in Brazil, in all Brazilian regions, some more than others, possibly due to the restrictive measures, including limitation of the consultations in public health services. And they found that their evaluation found that Brazilian average deficit in cancer diagnosis reached 35.5%, corresponding to about 15,000 undiagnosed cases of cancer monthly in this period. Now in Brazil, we just had the 18th of September is the National Day of Awareness and Encouragement of Early Diagnosis and Retinoblastoma. Several Brazilian institutions promote campaigns on this date, and from this year, for example, GRAC Hospital campaign, hashtag Hey Flash Saves. It's great. It's a support group for adolescents and children with cancer. And they had the campaign that is still occurring. And they also launched a booklet to clear up any doubts and enable those who take care of children, such as parents, teachers, caregivers, all of them who take care of children, to learn more about this type of cancer. So this was the last slide. I would like to thank you so much again. We believe that together we are stronger, that together we can achieve our goals easily. And I'd like to thank you once more again, the opportunity to be here. Thank you.
Okay, thank you so much for that fabulous presentation, Viviane, and it's been a real pleasure having you on board today and working with you in the last sort of 12 months.
Yes.
I think the world is that much smaller than it's ever been. So in the interest of time, I'm just going to jump in, and I need no real introduction because I think you've all heard about what I've done in the past over the last 2 days. And I just want to share with you what we've been doing locally in Australia. And the realization, I guess, that the whole certainly is greater than the sum of the parts. This presentation I give on behalf of the Retinoblastoma Australia-New Zealand Alliance, and you can see lots of logos here from all the various children's hospitals across Australia and New Zealand. There's from Adelaide, Queensland, Sydney, Perth, Melbourne, my hometown, and Auckland, of course, and my research institute and the National Health and Medical Research Council, which basically funds me to do a lot of my retinoblastoma research work. So these are looking at this map of Australia and New Zealand, we have collectively 6 centres that treat children with retinoblastoma in Australia. But unlike the presenters before me, we are an enormous country with a very small population. As you can see here, the entire landmass area of Europe and the United Kingdom combined would fit into Australia with lots of space left over. And when we consider the USA, Australia is not that much smaller in landmass compared to the USA at 8 million square kilometres, compared to the USA's 10 million. So our problem is that we are a geographically dispersed people. We have a very low density population. As Cheryl mentioned on day one, I think it was, at 3 in the morning, it's a little bit hard to remember all of this. You know, our population are sort of concentrated in the main capital cities, but for some families, they're out in regional and rural areas, and they do have to travel quite a way to come into the centre in the closest centre in their capital city. For some children, they may actually be closer to a capital city that isn't even in their state. That said, you know, the number of children diagnosed each year in the states of Australia can, in each state or centre, can range from 1 per year to about 5 or 6 in the larger cities. The incidence of retinoblastoma for Australia, New Zealand populations has been published in the literature only twice for Victoria or Victorian Tasmania, once for a New South Wales population and once for New Zealand. And, you know, collectively we have about 70, we decided to try and work together to put some data together for the International Society of Ocular Oncology meeting that was held in March 2017. So we looked at a 3-year period because that was probably a very manageable number. And in that time, we had 70 children that were newly diagnosed across the ANZ, which averaged around 23 per year and still sort of compares favorably with what is published around the world, 1 in 15,000 children. The average age at diagnosis of children with unilateral disease is around about 2 years of age, and children with bilateral disease around about 9 months. Children with a family history of RB are obviously much younger because we are very fortunate to be able to do a lot of screening early on. So they're just shy of 3 months of age, but some are diagnosed from birth, or as in the case of one of our patients was diagnosed even before they were born. Although children without a family history with retinoblastoma, the average age that they're diagnosed at is around 20 months. In terms of what treatment modalities that are available across the ANZ, just about all treatment modalities are available, although intravitreal chemotherapy is not yet being used in South Australia or WA at the time of collecting this data, but there is no reason why that wouldn't be available now, because from a technique point of view, it is very straightforward. Intra-arterial chemotherapy has been available only in my centre in Victoria, so all children who required intra-arterial chemotherapy were transferred to the Children's Hospital in Melbourne to receive this treatment. However, in April of this year, Sydney Westmead Children's Hospital were also able to offer IAC. And given this time of the pandemic, there's been sort of movement of children all over the place, and some having treatment in Sydney and then being transferred to Melbourne, depending on how out of control the pandemic infections have become, because we've had a lot of issues with state borders being closed. In terms of service delivery, we have specialist ophthalmologists in each centre, we have oncologists in each centre, we have a coordinator in each centre. However, only 2 have an orthoptist, like myself, in that role. Otherwise, it's usually a nurse. We have child life therapy, genetic testing across a number of different labs, and of course, we have genetics for support. And after this, you know, we showed that we were able to work together to collect data. And so we decided that, you know, we should perhaps work more collaboratively together. So what we did was we had an inaugural meeting in 2017, and we resolved to concentrate on contributing, collaborating, building capacity, and developing consensus. And at this meeting, there were representations by the ocular oncologists and ophthalmologists that work in the retinoblastoma space, pediatric oncologists, interventional radiologists, coordinators like myself. And together we have been able to progress some of these resolutions. We meet online every 4 weeks, the ophthalmic team, after our very busy Wednesday RB operating list. And we discussed any children that have been newly diagnosed or have relapsed, so we develop more of a consensus opinion. We've got early discussions in play at the moment in terms of developing a retinoblastoma registry that won't just record children who are diagnosed in Australia and New Zealand, but that will follow them through their lifetime into adulthood, because currently the registry that does exist is only a paediatric registry. We're building capacity. My work with the SIOP Oceania Advisory Board, looking at developing capacity for in-country treatment in our neighbouring islands. Collaborating, we've been able to support research with the Global Retinoblastoma 2017 cohort that has resulted in 3 publications to date, led by Didi Fabian, who we'll hear from later today. And we are about to publish the 11-year Australian experience of intra-arterial chemotherapy. I've spent a bit of time in advocacy working with my Queensland and New South Wales counterparts to, I guess, further develop the retinoblastoma care coordinator support model. And we also are now sharing sharing resources via a centralised secure platform at the hospital. And we look forward towards developing consensus screening guidelines for Australia and New Zealand health system in particular, and developing optimal care pathways. And so I leave you with this image of some of us at our first inaugural Team Rabanza meeting. The present, as I said, involved oncologists, ophthalmologists, care coordinators, interventional radiologists, and the radiology team themselves. But in the future, we look towards involving more fully pathologists, child life therapists, geneticists, genetic counsellors, nurses, anaesthesiologists, ocular prosthetists, and of course, central to all of this are parents and survivor advocates, because they are the people, you are the people that drive what we do every day. Thank you.
All right, we have time for 1 or 2 questions.
I've got a question if there isn't one. This is to Viviane. Viviane, so does Rio de Janeiro look after all the children in Brazil, or are there other centres that might do some treatment, for example, if they just require a primary enucleation?
Yes, we have another centers in another states. São Paulo, in the south region of Brazil, we have other centers. We didn't have access to their information, but the INCA, it's the National Institute of Cancer, and it receives children from Rio and from another regions from Brazil too.
Okay. Thank you.
Okay.
We have a question from Genevieve. How do our professionals across countries share information?
Min, do you want to start with that? Or Viviane?
Oh, okay. We don't have a center where we have all this information collected. So Dr. Matosinho, who wasn't able to be here today, is the head one in the National Institute of Cancer, but they don't have a place where, or a committee where they have this collected. For sure, they have something collected in the Ministry of Health, but we don't have a place where we can go and research about this. We have to ask to every person personally. We can say that. Okay, made I'm clear?
Yeah.
Okay.
Yeah, I think
we don't have a center, a national center here in Brazil.
Yeah, I think also, I guess the way we share information internationally on an international level, what you're talking about there is nationally. On an international level, I think it's done a lot through conferences, but the challenge is that at a conference, you know, retinoblastoma represents in pediatric ophthalmology such a small component, and sometimes people's eyes glaze over because we are a very small community of clinicians that work in this space. Yes. So I have found that by presenting at pediatric oncology conferences and at cancer survivorship conferences, there is more of an appetite and an interest in retinoblastoma because it's almost like I've found another tribe, really, and I belong more in the oncology space than I do in the ophthalmology space.
Yes, it's a pity. I think they It would be so better to have collected all the information together, so you can plan the work, you can see where you have to be more and act more, but
Yeah.
until today we don't have.
Yeah. And certainly some of the work that Didi Fabian is doing in trying to collect data globally has really pushed this forward and really demonstrating where the problems lie in terms of global health and inequity in access, and demonstrates what we in high-income countries can do to better support low middle-income country resources. And, you know, until we combine our data all together, we will, you know, no, rather, as we combine our data together, we will be in a much better position to move forward and better understand retinoblastoma and survival and all the issues that come with it.
Yes.
Excellent. We have time for one more question if there is one. Otherwise, we will go to a quick break and set up for our next panel.
Cindy Mays asked a question. Is it law that children are screened at well child visits?
In Australia, each state's got their own rules. All children will have a red reflex examination at birth, but after that, they have assessments with the maternal child health nurse, but it's not law that parents attend. And we really do rely on parents recognising signs and then reporting them to their health officer. Some states may do red reflex, but that's something we're working on collectively at the moment to improve that process.
Here in Brazil, we had the red reflex law in maternities before discharge of the newborn, but in some states we don't have, as far as I know, a national law. And just this, in Rio, we set this protocol to perform the red reflex until 4 years old. And so during the child care examinations, the pediatrician performs the red reflex in some appointments until 4 years old, but we don't screen everybody with this purpose.
In Vietnam, we only the children has a recognize a glow by the parent, and they go directly to the eye hospital. So now we want to improve the complaints about the nose glow because the ophthalmologist we try to explain and to introduce the pediatrician and the general doctor to discover the glow for us, because of that. So we have some the very advanced state of the children come to us, but now the on the time we could improve that.
Wonderful. Thank you. Thank you to Min, to Vivian, to Clarissa, Swathi, and Sandra for a great presentation.